This meeting is being recorded.
Welcome, Rohini ma'am.
Continue.
मैम अभी स्टार्ट कर दीजिए.
Okay. Good evening, all. Myself, Professor Dr. Rumjum Singh, Department of Homeopathic Pharmacy, Baxter Homeopathic Medical College. Welcome all the guests here and the speaker. Let me introduce AIHSAYA. The AIHSAYA, All India Homeopathic Student Association and Youth Association, was established on 31st October 2009 at Kolkata, West Bengal. Birbhum Vivekanand Homeopathic Medical College. AIHSAYA is a national level organization that aims to promote homeopathy and empowers the student and youth in the field of homeopathic system of medicine. With a strong presence across India, AIHSAYA is committed to advising use traditional Indian system of medicine, improving research sector, healthcare accessibility, and integration homeopathy with modern technology. Kashmir to Kanyakumari, Joy Homeopathy, and Gujarat to Guwahati, Gargar Homeopathy. Let's join hand to promote Ayush practice globally, strengthen Ayush infrastructure and research sector, integrate Ayush with modern technology for comprehensive healthcare. Together, we can make India a hub of Ayush excellence and contribute to global health and wellness. Today, our guest is Dr. Shailendra Bhamar. He is Professor, Practice of Medicine, LR Shah Homeopathic Medical College, Gujarat. And today's topic is holistic harmony, homeopathy in leukemia care. I welcome Dr. Shailendra. Uh, Now
Yes.
you can start your presentation.
Thank you so much, ma'am. I'm greatly, very much happy to be here. Uh, how much time do I have in my hand?
Yes,
कितना
please.
time है मैडम मेरे पास में?
Uh,
How much time?
I think it's right now it's 7:51. We'll
Yeah.
conclude by 8:25.
Okay, sure. So I'll just make it up. Thank you, ma'am.
Yes. Okay. Welcome.
So, I am here in front of you, myself, Dr. Shailendra Bhamar. I am HOD and professor in the practice of medicine, AIHSAYA Homeopathic College, Gardi Vidyapeeth. I am presenting here on the topic where we'll be telling about the holistic harmony, homeopathy in the leukemia care. Is my screen visible, madam? We have
Not now.
should I continue like this?
If it is not visible, then you can continue. Dr. Lavanya, can you help? Otherwise, you start your presentation, sir.
Yeah, okay. Uh, First, we'll see what leukemia is, the definition of leukemia, and how it occurs, what is the pathogenesis behind leukemia. So, leukemia, it is a group of the neoplastic disorder where it mainly affects the leukopoietic tissues in the body, and it is characterized by the presence of leukocytosis. We have immature leukocytes are there in the peripheral blood, and we have the maturation or the proliferation of this in the bones also, and they start suppressing the normal tissues. The etiology behind this, as it is a neoplastic disorder, as all of us know, we don't have the exact etiology, it's unknown, but there are some sort of genetic factors which have been associated with leukemia. It might be seen in the identical twins, Down syndrome, Mongolism, the Fanconi anemia is there, even there we can see. or it can be seen in the side effects of cytotoxic drugs, particularly the alkylating agents which have been there. And also it has been seen where after the exposure to the atomic bomb on the Hiroshima Nagasaki, the atomic bomb was been there. So because of that, side effects can be there. It has also been seen after the use of the radiography, the X-rays and all. So what happens actually in leukemia? We have the pathophysiology behind this. The defect is usually the unregulated proliferation of the primitive cells without undergoing any kind of differentiation. So we have the hemopoietic stem cell. Out of that, we have the myeloid series on one side, and we have the lymphoid series on one side. Okay, so the transformation into the leukemic cell, it can occur at any point of the maturation, and the differentiation of the pluripotent stem cell. So we have usually acute and chronic type of leukemias. In acute leukemia, there is proliferation of the primitive cells, and it will be leading to the accumulation of the blast cells within. And predominantly, the blast cells are there in the bone, which causes the failure of the bone marrow. And in chronic, we have the malignant clone, which is able to differentiate, and it is resulting in the accumulation of more mature cells, and those have been called as the sites, like the lymphocytes or the myelocytes. Then we have the classification of the leukemias. We have two classification. One is by the WHO, other is by the FAB classification, that is the French American British classification. We have the acute lymphoblastic leukemia, acute myeloid leukemia, chronic lymphocytic leukemia, and the chronic myeloid. After that, let's see different types of leukemias. We have the acute ALL, which we call it as the acute lymphocytic type of leukemia. It is mostly common in the children, especially the 1 or 2 decades, and the peak incidence is of around 1 to 5 years. It is mostly seen in the children. The clinical features of this, the patient usually is having no specific symptoms initially, but as the age advances, the patient starts having the fever, malaise, prostration, there is pallorness, which is followed.
Sorry to interrupt, sir. Sorry to interrupt, sir. Sir, within a while, we are just sharing the PPT, sir. Don't mind. And
Sure, sure. That's okay.
okay. Whether the PPT is visible, sir?
Yeah, it's visible.
Sir, if you don't mind, can we know which slide, sir?
I am at 22,
22.
21.
Acha, 21. This is the slide, no, sir?
Yeah, that is correct, one. Thank
Okay,
you.
sir. Thank you. Thank you, sir.
So should I continue with? We have the acute lymphoblastic type of leukemia, the first one. This is usually seen in the children or 1 or 2 decades of the life. And when we go for the clinical features of this, in the initial stage, we don't find any kind of specific symptoms. But Afterwards, the patient might suffer with fever, malaise, prostration. There's pallorness, and bleeding tendencies are in there. The patient is having purpura, ecchymosis. Because what happens actually in such conditions, the blast cells, they accumulate so much in the bone marrow that the other cells, they don't get the place over there. So we have decrease in the red blood cells, we have decrease in the platelets. So that is going to lead to anemia and the thrombocytopenia. So that is what they have mentioned here in the clinical features. Then the person is often also suffering with arthralgias, arthritis, neurological involvement has been there. Moving on to the next type, we have the AML, that is the acute myeloid leukemia. This is usually because of the failure of the maturation of the myeloblast. When the myeloblast, they don't get matured, so this condition comes. It is seen in both the sexes, both genders have been affected. But here, the most important thing is the lymphadenopathy and the hepatomegaly. These have been absent, but these can be seen in the myeloid type of series. Then afterwards, when we go further, uh, the investigation of such conditions, in all such, whether it is the ALL or whether it is the AML, anemia has been there. It is usually present. The leukocyte count, it might go from 20,000, 30,000, or 1 lakh, 2 lakhs also it can go up to. And these cells, they are not matured enough. And in 10 to 20% of the cases, you can see the subleukemic leukemia. Platelet count is also been reduced. The normal WBC count, if we see infants, children, we have different ratios for that. And into the peripheral smear, whenever we are going for the peripheral smear, very typical type of diagnosis we see here. We have the appearance of the blast cells over here and the presence of the OR rods in the cytoplasm of the myeloblast, which is very typical of the acute myeloid leukemia. Then in the bone marrow examination, we have the hypocellular lymphoblast or the myeloblast type of the bone marrow has been seen. And then we have the cytochemistry. We go for different staining, like the myeloperoxide staining or the PA staining is with there, which will be giving the Sudan black color, which is suggestive of that it is the positive type of this thing. Then the prognosis, I'll just skip all this. I don't have much time.
Sir, sorry to interrupt. Sir, you can
Yeah,
take time because
okay.
due to technical issue, we extend our time.
Yeah, sure. That is okay. Then
Sir,
I'll continue.
don't skip. Okay.
Okay.
Thank you so much, sir. Okay.
So in the peripheral smear, we come across OR rods, we come across the appearance of the blast cells, and then the cytochemistry has been there, where we are going to stain stain with some special chemicals like the myeloperoxidase staining, which is going to give the Sudan black staining, and which is very positive in the AML cases, or different the TDT positive. It is positive in the ALL, that is the terminal deoxynucleotide transferase. And then we go for the immunophenotyping. In this, the immunological cell markers have been there. Different varieties have been there. The T cell leukemia, the pre-B cell, the pre-B cell, this kind of markers have been there, which is going to suggest you. And then there's the immunohistochemistry has been there, by which we view the immunoperoxide levels have been seen, by which we'll understand whether it is the ALL case or it is the AML case. Then we have different karyotyping. We have the PCRs. Many a times we see the translocation of the chromosomes has been there. Okay. So on one side we have the ABL gene, on the other side we have the PCR gene. So in chromosome number 8 or chromosome number 22, there's a translocation between these genes, and that is going to get mutated, and the person is going to suffer with the leukemia. Then the favorable factors, when the WBC count is less than 20,000, the platelets are more than or the distance 1 lakh. It is seen mostly in the younger age group. We see absence of lymphadenopathy, hepatosplenomegaly has not been there, and it requires the early institution. The patient should be admitted very early. Then we have the management. The bone marrow transplantation can be done. The stem cell transplantation can be done. Radiotherapy, chemotherapy, these are all the parallel line of treatments which go. I'll deal with homeopathy in a span of time. Then we have the supportive infections, the supportive type of treatment. If the person is having many infections, sterilization, everything can be done. Anemia, thrombocytopenia, bleeding disorders, everything can be corrected by the other methods. The person is also might be suffering with hyperuricemia, nephropathy can be seen, the metallocarbolic problems can be there, there can be psychological problems, everything has to be dealt with. Then that was all about the acute type of leukemias. Now moving into the chronic type of leukemias. In the chronic type, we have the chronic myeloid leukemia. Chronic myeloid leukemia, here we see the proliferation of all the homeopathic lineages. We have different lineages in between. So the granulite series, we see the proliferation, and it has been called as the chronic granulocytic leukemia. The neutrophil leukemia, it forms almost around 95% of all the cases, but the basophils and the eosinophils, they might be affected, but it's very rarely seen. And this disease, it usually occurs in the elders or 30 to 80 years as compared to the acute type of leukemias. And the peak incidence is somewhere around 50, 55 or 60 years. Mostly, it is very rare below the 5 years of age. Then what is the cytogenetic or the molecular aspect? It is very important. This has to be kept in mind that the chronic myeloid leukemia, here the 95% of the cases of the CML, there we have the chromosomal abnormality, which has been known as the Philadelphia chromosome. That's what I was talking about. This is the shortened chromosome 22 and the result of a reciprocation translocation of the material with the chromosome number 9. And there's fusion of the gene BCR-ABL. So usually it is the translocation between the two chromosomes, that is the chromosome number 9 and chromosome number 22, out of which a new chromosome will be formed, and that gets mutated, and because of which the patient will suffer with CML. Etiology, we don't have the actual correlation with the cytotoxic drugs, whether the person was exposed to such the cigarette smoking. It accelerates the blast crisis. Atomic bomb survivors, they have the increased incidence of the CML. The pathology behind this, the granulocytes, they increase, and the precursors, they also increase. The bone marrow, it gets filled up with many types of granulocytes, myelocytes, metamyelocytes. These are the lineages which we find. And the blast cells, they are fewer, very less in number. So in a few percentage of the cases, the transformation occurs in the later stage, and the myeloblasts, they also can be higher in the number. They may predominate afterwards. The disease, it has 3 phases. We have the chronic phase, the accelerated phase, and the blast crisis. So it can be remembered by CAB. We have the mnemonic for that. The clinical presentation of such persons, it is generally insidious, means it's doesn't start all of a sudden. It is very insidious. So some patients, they are diagnosed while they are asymptomatic. During the health screening test, they might come across this thing, and they will be diagnosed with CML. The patient presents with a fatigue, malaise, there's weight loss, and resulting from splenic enlargement. Then the size of the spleen, it corresponds to the total leukocyte count, because the spleen becomes so much huge in the size. And the less common features which are related to the granulocyte or the platelet dysfunction, like the infections, thrombosis, or the bleeding, this also occurs, that we have already seen in the AML. Occasionally, the patient presents with leukostatic manifestations due to severe leukocytosis. Thrombosis is also been seen, that is the vaso-occlusive diseases have been seen. The cerebrovascular accidents, myocardial infarctions, venous thrombosis, priapism has been seen, the visual disturbances have been seen. And lymphadenopathy, we don't see any kind of lymphadenopathy. It is very unusual in such cases. Minimum to moderate splenomegaly, it is the most common physical finding. We can also see the enlargement of the liver also. In the complications of this, there's massive hemorrhage. It can be seen from the intraocular hemorrhage has been seen. infections, the recurrent infections, then anemia, malnutrition, splenic infarction, DVT, or secondary gout has been also seen, the blast transformation, most serious complications which causes the granulocytic sarcomas. What investigations can be done in such cases? The total leukocyte count, 1 lakh, it has been seen the cells per cubic millimeter. We can go for the differential count of the leukocytes, be the PNM, it can be the 40 to 50%, the myelocytes, the promyelocytes, and the rest of the monocytes, basophils, blast cells, they are also been seen, but they are very less in number. In the occasional smears, they contain only the mature type of neutrophils. Those have been called as the chronic neutrophilic or the ME Wells chronic myeloid leukemia. Anemia has been also been seen. The PLT is increased or it can be normal. Lab score is low or absent. Lab score is the very diagnostic of comparing between or to differentiate the acute type of leukemia with leukocytosis or the leukemite reaction. It is nothing but it is the leukocyte alkaline phosphate test. Then prognosis, the untreated average period of survival for the patient is 2 to 3 years. In well treated, 20% period of survival is 10 years. And death is due to the infections, the blast transformations, hemorrhage, and rarely due to the drug toxicity. The management of such cases in chronic phases, we have to inhibit the BCR, ABL, the tyrosine kinase activity. We can control this by proliferation of the WBC. Accelerated phase, the blast crisis, more difficult. Chemotherapy, radiotherapy, that goes hand in hand. Then we have chronic lymphocytic leukemia. This is the most common variety of leukemia, and it accounts for around 30% of the cases. It is very low in India, common in the Western countries. Male to female ratio 2:1. The CLL of the B, it is of two types: the B cell type and the C cell type. The 90% are small lymphocytes, nuclear chromatin, closely they are condensed, cytoplasm small to moderate in the amount. On the bone marrow, when we see it is patchy, nodular, interstitial involvement has been there. Then the CLL of the T cell type. The large granular lymphocytes, these are of moderate size, abundant light blue cytoplasm. Anemia, thrombocytopenia can be seen alone or can be associated with neutropenia. The pathology behind this, the pathophysiology behind this, most cases, these are of the B cell origin. The B cells, they undergo uncontrolled proliferation. They infiltrate into the liver, spleen, and the other organs. In this disease, the B lymphocytes, which would normally respond to the antigens by transformation and antibody formation, they fail to do so. And ever-increasing mass of the immunocompetent cells, they accumulate to be detriment of the immune function and normal bone marrow hematopoiesis. Then the clinical features we see here, the onset is very insidious. 70% of the patients they have been diagnosed. They meet incidentally on a routine full blood count. The presenting problems, it may be anemia, generalized painless lymphadenopathy has been seen, systemic symptoms such as night sweats, weight loss. These are often, they occur later in the progress of the disease. Lymph nodes, they are moderate to large in the size. They are very discrete, rubbery in consistency. Usually when we palpate the lymph node, they don't look rubbery. Enlargement of the lacrimal salivary gland, they have been associated with one syndrome, that is the Mikulicz syndrome. Liver is enlarged, spleen is mildly enlarged. Due to the immunosuppression, the increased tendency to infections, especially the respiratory tract infection, urinary tract infection. And we can see the pruritus also, which is very distressing kind of feature here. Investigations, the blood leukocyte count, 50,000 to 2 lakhs it may go. Mild but gradually increasing anemia. Platelet count is decreased. Peripheral smear, small mature lymphocytes can be seen. The lymphoblasts are rare. Many lymphocytes are ruptured, and those have been called as smudge cells or the basket cells. Electrophoretic studies have to be done. The serum immunoglobulin levels should be estimated to establish the degree of immunosuppression. Monoclonal proliferation of the immunoglobulin. Bone marrow examination has to be done, and the LN biopsy also has to be taken. Then we have staging of this chronic lymphocytic leukemia. The stage 1, stage A, stage B, stage C. Stage A, we don't see any kind of anemia, no thrombocytopenia. Okay, so this is the first one. Then in the B stage, no anemia or thrombocytopenia, but there's involvement of the lymphoid environment. The lymph nodes have been involved here. In the stage C, we can see the anemia, thrombocytopenia, regardless of the lymphoid enlargement. Then coming up to the prognosis, the overall survival for the patient is somewhere around 6 years. That was all about the allied part of the leukemia, acute and the chronic leukemia. Let's see the homeopathy part, how useful homeopathy is. When we go into the repertory, I have gone into the Murphy clinical repertory, where I found out the rubric leukemia. In that, the medicines have been graded, and the other rubric is the acute one, and the next rubric is children acute in. Then we have lymphoid as a rubric, the spleen involvement. In this, they have indicated the medicines, and we can go for this. We can grade and we can go for the total grading. Then we have the synthesis. In the synthesis, the rubric is leukemia. Other rubric is children in, and the next rubric is pseudo leukemia. In this, there are some kind of indicated medicines have been given. Let's go into the therapeutic part of this leukemia. The first medicine which goes into my mind is the arenia medicine. We see here the spleen becomes very much swollen, the bone pain in the extremities. All symptoms, they have been characterized by the periodicity, coldness, and great susceptibility to dampness. The patient feels cold to very bones. The coldness, it has not been relieved by anything. The pain is so much that sensation of sweating and of the other parts, they're going to sleep. The patient feels that. The next is the AIHSAYA. It is indicated profound prostration, rapid irritable pulse, recurring fever, sweats, emaciation, tendency to diarrhea, great emaciation, recurrent fever and sweats, drenching night sweats, chilly, cannot endure the cold. Next, we have the arsenic album. It maintains the system under the stress of malignancy, regardless of the location. Among these, the all prevailing debility, exhaustion, restlessness, nightly aggravation, it is most important. Great exhaustion after the slightest exertion, that is a chema, burning which is relieved by heat, anemia, chlorosis. There's gradual loss of weight from the impaired nutrition, reduces the refractive index of blood serum. You can refer China and Ferrophos also. Then we have benzonium. The most striking fact in the proving of the benzol, it seems to be the influence of it had on the circulatory system. In the human provers, it resulted in a decrease of the red and the increased white cells. It ought to be very useful in leukemia. Then we have Calcarea carp. Its chief action is centered in the vegetative sphere, especially impaired nutrition being the keynote for its action. The glands, the skin, the bones, they are being instrumental in the changes wrought. Increased local and general perspiration, chill at 2 p.m. begins internally in the stomach region, fever with sweat. Night sweat, especially on head, neck, and chest. Then we have Calcarea fos. Anemia after acute disease, chronic wasting diseases, anemia, children who are peevish, flabby, having cold extremities, feeble digestion. Numbness and crawling are the characteristic sensation. Tendency to perspiration and glandular enlargement as symptom it shares with the carbonate, scrofulus, and the chlorosis. Then we have next the carcinosin. It acts favorably and modifies all cases in which either a history of carcinoma can be elicited or symptoms of disease itself exist. Indigestion, accumulation of gas in the stomach, bowels, rheumatism, cancerous cachexia. Next, we have cyanothus. This remedy seems to possess a specific relation to the spleen. Anemic patients where liver and the spleen are at fault active hemostatic, the materially reducing the clotting of the blood, deep-seated pain in the left hypochondrium, hypertrophy of spleen, leukemia, unable to lie on left side, pain in the liver and the back. Next, we have China, debility from exhausted discharges from loss of vital fluid, together with a nervous erythema, calls for this remedy. Periodicity is most marked, sensitive to draughts, seldom indicated in earlier stages of acute disease. Liver and spleen swollen and they are enlarged. Next is the perim picricum. It is useful in the pseudoleukemia. It's considered a great remedy to complete the action of other remedies. Next, we have natron salt. It is a liver remedy. Hydrogenite constitution, liver sore to touch, sharp stitching pain, can't wear the tight clothing around the waist, then ameliorated by lying on the left side. Next medicine is picric acid, neurasthenia. The muscular debility has been seen here. Heavy, tired feeling, progressive pernicious anemia, great weakness, tired, heavy feeling all over the body, especially the limbs, and worse exertion. Next is the X-ray. When the person is repeatedly exposed to raw antigen or the X-ray, it produces the skin lesions, often followed by cancer. Changes take place in the blood lymphatics and the bone marrow. We see anemia and leukemia has the property of stimulating the cellular metabolism, arouses the reactive vitality mentally and physically, brings to the surface suppressed symptoms, especially psychotic, and those due to mixed infections. Its homeopathic action is thus centrifugal towards the periphery. Next, we have the radium bromide. Radium bromide, it is marked, it is indicated in increase in polymorphonucleoleucocytes. There, it has been very much rightly indicated, the radium bromide medicine. These are the references from which I have made this PPT. So that's all for my presentation today. Thank you.
Thank you so much, sir, for your insights and about the topic. Uh, I would like to open the question answer session. If anyone is having any doubt, kindly ask. Anyone, please?
Well done, Bhamar sir.
Thank you so much, sir. God yeah, bless it. Got some technical issues, but it's okay.
It was very good session.
Thank you so much, sir.
I had whole session, sir.
I'm blessed. Thank you, sir.
थैंक यू अनूप सर, आपने तो पूरा टाइम देखा तो बहुत अच्छा लगा आपने।
हाँ जी सर।
हाँ?
अनूप सर थैंक यू सो मच। अनूप सर आपका
हाँ,
आपने आपका valuable टाइम दिया है, आपने ये जो पूरा से वेबिनार सुना है। और सॉरी सर, हम लोग का टेक्निकल इशू है, इसलिए बहुत दुखी हूँ मैं।
you are not clearly audible. Dr. Kingshu,
जी सर।
not clearly audible.
Voice is cracking, sir.
Actually, the last time also I was having some technical issues where my audio was not working. This time also I faced the same problem. Then I joined from my mobile. So,
Madam, it's a
so
problem. It's a problem whole India. It is the problem whole India. And we are frequently suffering this kind of situation, and how we can overcome. Our government should think regarding that. It is the big issue now.
I would like to say something regarding AIHSAYA. All this, as a National Executive Member of Scientific Committee of AIHSAYA, I am proud to say that our organization is committed to promote homeopathy and traditional Indian system of medicine. And this webinar series is being conducted on the occasion of 12th Ayush Vigyan Sammelani 2025. And the author Ayush Mahotsav 2025, celebrating the centenary of former Prime Minister late Atal Bihari Vajpayee. So we are continuing this type of webinar during this month. And Dr. Kingsuk, you can say detail about the webinar series till up to how many days we are going to conduct it.
मैम हम लोग का जो आयुर्वेदा योगा यूनानी होम्योपैथी से हम लोग जो सेंट्रल रिसर्च वो लोग से हम लोग फिजिकल को चुने हैं। तो अभी हम लोग का आयुर्वेदा लोग कुछ आया है स्पीकर का टाइम और भी आएगा पूरा दिसंबर तक चलेगा। अभी नवंबर में स्टार्ट हुआ था तो अब दिसंबर तक चलेगा पूरा प्रोग्राम। कुछ में एक आयुर्वेदा योगा लास्ट सिद्धा वाला आए थे। सिद्धा का जो रिसर्च सेंटर है गवर्नमेंट ऑफ इंडिया का सिद्धा रिसर्च सेंटर है उसमें आया था। उसके पहले आयुर्वेदा के टीचर भी आया थे। ऐसे जो जहाँ भी रिसर्च जो हो रहा है तो रिसर्च को हम लोग चाहते हैं जगह होम्योपैथी में जो रिसर्च हो रहा है सीसीएस जो रिसर्च उसको घास रूट लेवल पे लेके जाए क्योंकि बहुत सारे डॉक्टर्स है जो लोग प्राइवेट प्रैक्टिशनर है वो लोग को जो है सीसीएस जो रिसर्च करते हैं उसके बारे में कुछ पता नहीं चलता है। तो हम लोग कोशिश कर सीसीएस के बंदे लोग जो रिसर्च कर रहे हैं जो जो सेंटर चाहे आनंद निकोबार द्वीपपुंज हो काश्मीर हो गुजरात हो चाहे आपका कलकत्ता हो यहाँ पे बहुत सारे क्लिनिकल रिसर्च चल रहे हैं होम्योपैथी में। जैसे एनिमल के ऊपर होम्योपैथी मेडिसिन कैसे काम करते हैं उसके ऊपर रिसर्च चल रहा है। एग्रो होम्योपैथी बोल के है जो हम लोग होम्योपैथी मेडिसिन कैसे एग्रीकल्चर में प्रयोग होगा उसके ऊपर रिसर्च चल रहा है। तो ऐसे जो रिसर्च चल रहा है वो जो रिजल्ट आया है उसको हम लोग घास रूट लेवल तक लेके जाना चाहते हैं। होम्योपैथी डॉक्टर्स की प्राइवेट प्रैक्टिस बहुत से प्राइवेट प्रैक्टिशनर जो बहुत अच्छा अच्छा पेशेंट को ट्रीटमेंट देता है अच्छा क्योर करता है तो उसका भी डेटाबेस जो प्राइवेट प्रैक्टिशनर है वो जो पेशेंट के क्योर करता है उसका डेटाबेस भी हम लोग का रिसर्च सेंटर को एक स्टेप लेना चाहिए उसका डेटाबेस हम लोग को ऑनलाइन पे मिल जाए। तो आई थिंक गवर्नमेंट ऑफ इंडिया का जो आयुष मिनिस्ट्री उसका एक वेबसाइट है जहाँ पे रिसर्च प्रपोजल बोल के हम लोग रिसर्च वेबसाइट है जहाँ पे हम लोग रिसर्च डाल सकते हैं। हम लोग क्या क्या होम्योपैथी प्राइवेट प्रैक्टिशनर जो प्राइवेट में प्रैक्टिस करके क्योर किया है उसके ऊपर हम लोग क्या ट्रीटमेंट किया है उसको सबमिट कर सकते हैं। तो इसके ऊपर तो अभी जो हम लोग का अनुप सर है अनुप सर भी अच्छे से बोल सकते हैं। सर हम लोग का रिसर्च का फ्यूचर होम्योपैथी का रिसर्च में क्या स्कोप है और हम लोग को जूनियर रिसर्च फेलोशिप और सीनियर रिसर्च फेलोशिप तो निकलता है। तो हम लोग चाहते हैं इंडिविजुअल फेलोशिप इंडिविजुअल जो होता है प्राइवेट प्रैक्टिशनर डॉक्टर वो लोग को कैसे हम लोग रिसर्च में इंक्लूड कर सकते हैं। जैसे हम इसमें गवर्नमेंट ऑफ इंडिया का क्या पॉलिसी होना चाहिए कैसे वो गवर्नमेंट ऑफ इंडिया पॉलिसी का जैसे हम लोग प्राइवेट प्रैक्टिशनर भी रिसर्च का जो फ्लो है मेन फ्लो उसमें हम लोग घुस सकते हैं हम लोग को कुछ बेनिफिट मिल सकता है। बहुत सारे डीएमएस डॉक्टर मैंने देखा बहुत सारे होम्योपैथी डॉक्टर मैं आयुषा का फंड कलेक्शन के लिए मैं बहुत जगह जाता हूँ तो देखा डीएमएस डॉक्टर जो है 80 ईयर्स का हो गया 70 ईयर्स वो लोग बहुत अच्छा होम्योपैथी मेडिसिन प्रैक्टिस करता है। जो लोग डीएमएस है नो बीएचएस नो एमडी वो लोग अच्छा से पेशेंट देखते हैं बहुत बहुत सारे केस है जो अच्छा रिजल्ट देते हैं। तो वो लोग का जो केस है वो लोग जो रिसर्च काम कर रहा है उसको हम लोग कैसे मेन स्ट्रीम में हम लोग होम्योपैथी में लेके आ सकते हैं उसमें गवर्नमेंट को कैसे पॉलिसी होना चाहिए। ओवर टू यू सर।
In this context, I would like to say कि whatever the practitioners, whoever the practitioners, they should maintain the proper record of their cases with
अनुप
proper
सर आपका
data.
म्यूट है। अनुप सर आपका म्यूट है।
Proper data should be recorded in proper format, including
Madam,
the follow-up. Then we
who
can
is
present your research work at any field, any platform.
actually as an academician and as an administrator, what I can feel now, government is more emphasizing on documentation like whatever they are doing, evidence-based, they are trying to do. But in homeopathic viewpoint, there are so many things which is not still now not possible to establish physically. So what we are doing now in classroom, we are making so many documentation regarding any other than education. We are organizing yoga, we are organizing plantation, we are organizing so many events other than education, which actually homeopathy education should perceive our students, and it must be motivated by our teachers. But as the teachers, it is my views that we are going to be a good clerk. Teachers are going to be a good clerk, and government should think regarding that. So many stalwarts, they are making rules, regulations, etc., etc. But as the academician and as the field worker, it is quite impossible to educate our students homeopathically. Actually, it is a mostly philosophy-based subject. Every student knows practice of medicine. As Dr. Bhamar sir will be very happy to know, every student know homeopathic medicine. Every student know surgery, gynecology, everything know. But they don't know what is organoid medicine, what is homeopathic philosophy, what is mathematica, how to study homeopathic mathematica. Very difficult to survive for homeopathy. And government is more emphasizing on clerical based work nowadays. This is my perception. Maybe wrong. Due to my limitation, it may be wrong, but what I can think. So, government should think regarding this and our scope of job. Actually, now Gen Z generation, they wants earning first before making themselves as a physician, established as a physician. They just want to earn money, more and more money. So government facilities towards and privatization of education, homeopathic system of education, it is also a great, I think, it is my perception. So it is very difficult, and government should think regarding that, and I hope AIHSAYA can take initiation regarding this.
Yeah.
So if you can do successfully, then it may be we can achieve something. Otherwise, future is very dark. It is my perception. Maybe
Right,
wrong.
Right, sir.
Thank you, Dr. Kinsugan, madam.
Thank you, sir. Thank you. Thank you, sir, for your valuable time. Over to you, Dr. Lavan, ma'am.
Yeah.
Yes, sir. Thank you, sir. Thank you so much for the overwhelming session. And we are glad that today we have learned about many things regarding the leukemia, and we will be glad that to have many more sessions also. So
Yeah.
right now,
Sure.
yes, sir. Yes, sir. We'll be glad to look many forward sessions also, sir. And thank you, sir. Thank you so much. And thank you all the participants. And the registration form link has been given in the comment box. So those who want to register for the further webinar and also for the today's registration who want to get the e-certificate, they can also fill the form. And thank you all. Thank you so much.
Thank you.
Thank you, sir.
Thank you, all the dignitaries and all the participants. Thank you, I say, for
Good night to
organizing
all of
such
you.
type of seminars.
Good night, sir. Good night.
Thank you, Rumju ma'am. Thank you, Rumju ma'am.
Thank you, Dr. Kingsuk. Thank you.
Thank you, Dr. King. Thank you, sir. Thank you, everyone.
Thank you.
Okay. Did I leave, ma'am?
Yes, sir. Thank you, sir. Thank you so much.
Thank you.
Thank you.